Okay, so I just start with neuropsychology. Okay, so just a quick definition. Alright, I'm sure a lot of you know this already. So yeah, neuropsychology is essentially the link between brain dysfunction and behavioral/cognition. Yeah. And many of you who are not from psychology do not know this. It is part of clinical psychology, okay? I would even say that it's part of cognitive psychology as well, right? So generally it's focusing, on patients with cognitive impairments, right? So aging is definitely a huge part of it, a huge part, subdomain. Definitely is one of my primary research areas, right? Disease, injury, yada yada, right? There's a lot of things. And the neuropsychologists are essentially, but not always, okay, not always, licensed doctoral level clinical psychologists who completed specialized training. I think master level people are also fine, I think, in Singapore at least. So neuropsychologists, they focus on the cognitive consequences, right? Yeah, so you're supposed to, focus on cognitive assessments, right? And neurologists, on the other hand, they look at physical consequences, right? Because these are the MDs, right? And when it comes to neuropsychological assessment, we need to look at all these different goals, right, from diagnosis all the way until your treatment plan. And the conditions involved, right? The conditions, not just the patients, right? The so-called treatment plan, right? Intervention plan, right? All these things are very important. And standardized psychometric tests, I think we all know this, all right? Just want to highlight this battery, right? NRMB, yeah? So, sorry, it should be HRMB. Okay, I correct that, HRMB. And so this is a Halstead written neuropsychological test battery, a very large assortment of battery. So we'll look at one of the tests on the very next slide. Yeah. And then the last thing will be different conditions might affect test performance, pain, fatigue, medications. Yeah. So this thing is a trail making test. All right. I just want to see if the video works. Okay. Just give me a while. Let me just click on it. So okay, let's just watch this video for a short while. All right. Whoa, sorry about the noise. Yeah. What just happened? Alright, so welcome back everyone. So just now when you are watching the video, right, just take note, okay, the trail making test. The first part is super easy, right? Just linking up all the numbered dots, right? 1, 2, 3, 4, 5, 6, right? Very simple. Then part B, you guys see it, right? There's different levels, right? So yeah, depending on the number of items, right? So 1 with A with 2, 2 with B, B with 3, 3 with C, right? So yeah, so basically it's number, letter. Basically you have to chain all these things in the right sequence. Difficult, yeah. Particularly for older people, right? So now let's turn to, all these things that we call neurocognitive disorders, right? We look at this DSM-5, right? I'm sure everybody knows this, right? Diagnostic Statistical Manual of Mental Disorders. Essentially the Bible, right, for all clinical psychologists, yeah. And then whenever a patient experiences some decline in functioning, right, in one or more of these cognitive domains, we refer to this manual, right, yeah. And we shall start with dementia, right. It's a well-known neurocognitive disorder, right. I wouldn't say the word neurocognitive is the most prevalent word, right. The most prevalent word would be neurodegenerative. Okay, that is much more precise, okay, as written by some of you in your review papers, right? And then we all know that this is an umbrella term, right? Yeah, so there's so many different types of dementia. And there is more than what one would expect, right, based on normal aging, right? So, so the early phases of this dementia, right, so we'll not be able to remember how to get home, right? So spatial-wise, you'll be suffering from some spatial deficits. And then your declarative memory as well, not knowing what day or year it is. Planning, grocery shopping, your movement, right, all these things will be hindered, right? Inappropriate behavior, the last part will be quite severe, right? This is really the person is kind of really demented, yeah. Personality changes that is super severe, yeah. Okay, now we look at Alzheimer's disease, simply known as AD, right? It's the most common type of dementia, right? And this will be the only kind of dementia we got the time to focus on, right? Some of you presented this already, right? So again, we see the word neurodegenerative, yeah. So that will be the most precise word to use, right? So it starts with this thing we call MCI, or some people call it mild memory loss, MML. Okay, that's fine as well. So it starts with that, and then it leads on to higher order cognitive functions, right? So the early phases will just be like what we saw on the previous slide, okay? Forgetting where you are, okay? That is mild, right? Forgetting where you are, okay? When it's late, right, the late onset, then it's really, you cannot hold a conversation. There'll be personality changes. You will forget a lot of words, right? You'll suffer from incontinence, Okay, so that's very, very severe. Okay, not many people suffer from that, right? And then probable AD is diagnosed, right, on all this neuropsychological testing and biological testing. Yeah. And then for confirmatory AD, okay, this is really the catch. Not many people know this, right? To really actually confirm that somebody got AD, we actually need brain autopsy, right? And before that, there needs to be a PET, of course. Yeah. So okay, well, I get to that later, right? So before we do, right, we look at the genetics, right, all these genes, right, of AD, right. There's this epsilon 4 variant. It's actually the first variant. I wouldn't say it's a variant. It's pretty much a normal alleles to have. And later on, we have epsilon 2 and epsilon 3 happening. So just take note that having this epsilon 4 allele or alleles, right, 2 copies, right, is not a good thing, right. It just accelerates AD onset, right. If you have this epsilon 2 allele or alleles, okay, with the S, it means that you'll get some protection against AD. Okay, that would be a good thing, right? Epsilon 2 is a good thing. Epsilon 4, no. And then there are also mutations on other kinds of genes, right, coding for other kinds of proteins, APP, PSEN1 and PSEN2, right? And now, so this one, we look at all these different proteins, right, all these abnormal proteins, right? You have to know this, right? This is super important, okay? Okay, so the first one is neurofibrillary tangles, right? You can also see them as abnormal tau proteins. Yeah, so they're kind of triangular shape. Normally they hold all the microtubules of our axons together, right? Yeah, so this, they kind of broken down and then, they're not really decomposed. They become all these tangles. Terrible. And then we have this beta amyloid plaques, which is also simply called amyloid, right? But having the word beta is much more precise. Right, so I would encourage people to write the full term of it, beta amyloid plaques, right? And then basically the PET scan is just showing you, right, the AD patient has a lot of amyloid, yeah, not very good. And also remember the shape of it, right? Amyloid is more like a blotch, right? Tau is more like a triangle, like a pine tree. And Alzheimer's disease patients, they experience this deepening of sulci, enlargement of ventricles, very, very prominent, right? Especially enlargement of ventricles, right? And treatments, actually, there's not really any effective treatment, right? So far, maybe the most potent is this Aduhelm, right? Or aducanumab, right? You guys can read about it, right? It's all over the news, right? But it can cause brain aneurysms, right? Swelling, bleeding. So a lot of people file lawsuit against the maker of Aduhelm. The lawsuits went nowhere, okay? Unfortunately, yeah. It's very hard to sue the big pharmacological company. And then we have also this acetylcholinesterase inhibitors trying to increase the amount of ACH in the cerebrospinal fluid. Okay, maybe that's a bit better, right? And diet, diet I think it just slows down the progression of AD. Okay, particularly the omega-3 fatty acid. Right, okay, that's good for your brain. Yeah, and use of antipsychotics not very good. Right, yeah, those that's used to treat schizophrenia is also used to treat AD. They can lead to brain swelling as well. No good, right? Now we look at this vascular disease, this stroke, right? So just now I talked about brain swelling, right? So a stroke is close to that, not exactly a swelling, but it's an internal bleeding. So it's a cerebral hemorrhage, right? So it can be caused by hypertension, aneurysm, right? Is what I mentioned, right? And then the sudden blockage of blood vessel, right? So we see a lot of medical terms here, right? So ischemia, low oxygen level, right? Infarct. Sometimes it's also called infarction, right? But infarct is more like the area. Yeah, infarction is the event, right, of this infarct happening. Yeah, and then we have transient ischemic attacks, right? Yeah, so it's like momentary, and sudden attack of low oxygen levels. And then we have thrombosis and embolism. Embolism is much more specific. Applies to the arteries. Thrombosis applies to both arteries and veins, right? Blood clots can be any other substance as well. Can be some kind of fatty, tissue fatty substance, right? Not good to have, right? And so there's this glutamate release which can happen after a stroke, right? And that can lead to this thing we call excitotoxicity, the biological concept, right? So too much excitatory signals can just simply damage your cells, right? Damage the membranes especially. And the neuronal cell death can occur after a stroke, right? But prompt medical intervention, right? Attention can save the neurons and glia in the penumbra, right? Not in the core. The core is already suffering from loss of oxygen, right? So the penumbra is the surrounding region, yeah. So usually we use this word to refer to the moon, right? Yeah. So the dark side of the moon, yeah. Your moon gets shaded, that's a penumbra. Okay, and then use of drugs that reduce blood clotting, right? There's a lot of drugs, mechanical intervention, And there's this thing called the HDAC inhibitor, very, very interesting. So they stop the removal of acetyl groups from histones. So the histones are basically the structural support for the DNA. For the DNA, and then it's also used to treat cancer, right? So this is very interesting kind of drug. Surgery and physical activity. And now we turn to psychopathology, right? So a lot of words here. What does it mean to have a mental disorder? So involves disturbance in cognition, emotion, behavior that affects the psychological, biological developmental processes, right? Yada yada. So it's just it's a general and lengthy definition, right? And then we are going to cover all these things, right? Genetic vulnerability, structural differences in the brain, a bit of biochemical differences, right? The last thing about precision psychiatry is just individual focus kind of treatment, that's what we call precision medicine as well, Okay, so early influences on the gut microbiota. This is a very interesting box from the chapter 16. It took me some time to understand. So what the author was trying to say is that, there's different kind of prenatal and postnatal bacteria, that we grow up with, okay, in the mother's womb and after we are born, and then the way that we are born, right? Okay, it's like vagina versus cesarean. If you're born like the vagina style, traditional style, you get more gut microbiota, You get to have more bacteria, and those bacteria can sometimes be a good thing, can lead to healthy growth, right? Without that, you may be more predisposed to getting certain mental disorders, and that is quite interesting, So that's something that you guys can read up. Okay? It's just very good for your general knowledge. So mental disorders, right, are common as long as the Western countries like Australia is concerned, right? So I can't really get the data from Singapore. Okay, very hard to get reliable data, okay, or trustworthy data, right? So this is from the JCU site, okay, Australia. I think this thing is legit, right? So 1 out of 2 Australians lifetime, right? Because people do report, okay. 1 in 2 Singaporeans, no way, okay, no way. There's no data, right? 1 in 5 Australians over the last 12 months, right? So this is a bit like USA. USA is like 1 in 5, 1 in 4, okay, 1 in 4. So you can see that normally females are more likely to report, okay, that they got some diagnosis, especially when it comes to anxiety. But for males, it's more like substance use. Unsurprising. So for the next half of the lecture, I'll cover these 5 MDs, right? Mental disorders. ASD, ADHD, all the way until schizophrenia, right? So focus on MDD. MDD is super important, all right? As long as the quiz goes, right? So ASD would be what we call a neurodevelopment disorder, or simply a developmental disorder, right? So the person with ASD suffers from social deficits, right? Communication deficits. And then there's also repetitive patterns of behavior, a little bit like OCD, so there's a kind of compulsive things to repeat certain things. Again, it's an umbrella term, right? So we have things like Asperger's syndrome, other kinds of developmental disorder. Okay. The video you guys can watch, right? So it varies across individuals. That's why we use the word spectrum. So many children, they can make normal adjustments, but up to 60% can be intellectually disabled. So a bit unfortunate, right? And it's 4 times more prevalent in males, right? So this is a male dominant kind of disorder, right? Unlike the other few that we're going to look at, right? So it's increasing over the past 10 years. So I think it's more likely a relaxation or diagnostic criteria, so this is what we have in our textbook, right? It's 2010. I'm not so sure now. Now I think it should be more, definitely. Okay, so 2010 is about 15 per 1,000 children. So now we look at the brain structure and function in ASD. So they tend to be accelerated through early childhood, right, for ASDs. So the brain enlargement is pretty quick, but there's a period of deceleration, so there's kind of failure to growth or even some shrinking. And then the next slide will just show you differences in the structure of minicolumns. And then we also look at differences in sizes of amygdala, hippocampus, cerebellum. Okay, this I think some of you covered in your presentations. So there's smaller amygdala, cerebellum, but larger right hippocampus in ASDs compared with non-ASDs. And there's disrupted default mode network functioning, DMN, dysfunctions in mirror system functioning. So that's like our lateral prefrontal cortex, okay, that help us to kind of mimic certain behaviors. Okay, that is very, very controversial. Okay, it's not really replicated. So we look at this mini-column differences in autism. So there's this ASDs, they tend to exhibit reduced distance between minicolumns of neurons in the PFC, right? This is from the PFC, okay? So basically, it's kind of greater density. Like if you come to look at it, right, everything is more like squeezed together, the neurons, right? Throughout all the 6 layers, right? I think it's 6 layers of the PFC cortex, and then this ties in with the notion that ASD savants, right? So these are highly gifted people. They're not ordinary ASDs, right? These are possibly professors, right? They favor highly detailed local processing over global processing. So they're very, very detail-oriented. They don't look at the gist, right? They look at the details. Right, so next we look at how ASD is treated. There's not really good medical treatment. So our textbook didn't really focus much on that, because these are children. You don't want to give them some kind of medical therapy. So usually it's behavioral in nature or CBT in nature, right? So this is applied behavioral analysis. It's kind of a lower form of CBT, right? Not so much of the cognitive component, more of the behavioral component, right? And probably is the best approach, So step by step, the therapists get to nurse the child, and then we'll implement very, very small operations, right, to go and change the person's behavior, okay? And then the last thing is that there's no support for like gluten and casein-free diets. The gluten is from our bread, okay, sticky substance in our bread, and casein is from our milk, So it doesn't mean that, you get rid of this, your ASD symptoms will improve, right? No. Okay, so next we turn to ADHD, right? So it is like ASD, it is a neurodevelopmental disorder affecting children, but this is the most common psychological disorder. And then we all know what this is like. So as the name suggests, there will be inattentiveness. Okay, there can be impulsivity, there can be hyperactivity. So symptoms must interfere with, reduce the quality of social, academic, and occupational functioning. I don't really want to look at the genes because there's really nothing special about that. So we look at the brain structure, which is much more interesting, right? So this one, I think some of you presented, right? So, there's this delayed maturation, right? I would like to use the word maturation instead of saying that, these brain regions are just smaller, right? I do not think that is legit, right? It's more like delayed growth, right? Delayed maturation in these areas, right? Or in the frontal region, and then in our basal ganglia, right? Called the nucleus. And then a lot of you mentioned as well, amygdala keep coming up, right? So this is smaller at first, hippocampus also. But they can disappear during adolescence, okay, without the S, as the brain matures in ADHDs, So this is something I mentioned this morning, right? I think, somehow the ADHD people, they have a faster rate of brain growth. So I think it's just a faster rate of energy consumption later on during the teenage years, So how that really happens, I have no idea, right? So there can also be disruption in the DMN growth, right, default mode network. Okay, that's a small point. So now I would just want to talk about medications, right, for ADHD, right? So there's a few important popular drugs. Okay, Ritalin is probably the most famous, And then Adderall is amphetamine salts. These are all dopamine agonists, So, and Adderall, furthermore, it's also a norepinephrine agonist, right? So it prevents the reuptake, right, of norepinephrine. So it can cause sleep disturbance, can cause loss of appetite. So okay, not too bad, I would say. There's also non-stimulant drugs, right? The opposite, but they're kind of associated with increase in suicidal thoughts. And there's, people still take them. Doesn't really matter. All right, so the last part was the most surprising. So there's some kind of dopamine antagonists. Okay, that's used for treating schizophrenia. They're also used for treating ADHDs. That's very surprising. Very surprising. That just shows that, we do not yet understood the mechanisms, right? The neurochemical mechanisms underlying ADHD. So okay, it's just confusing stuff, right? Now we look at MDD. Okay, this is possibly the most well-researched disorder, and most of the time it's almost widely tested. So we'll focus on this. Right, so just focus on the period. So when you talk about major, it should be within 2 weeks, at least 2 weeks. At least 2 weeks. So you have withdrawal from activities. All right, you find pleasurable, disturbances in appetite. Okay, all these things, energy level, sleep condition, and the last part is a bit severe, right? Feelings of guilt, hopelessness, worthlessness. So last time, 5 years ago, it was about 7%. I think now it should be more than this, or even double of this, right? Not in our textbook, but I'm sure it's more than 10%, right? So it affects women more than men, right? and then prevalence rates decrease with increasing age, right? So you look at this graph, 50 or over in Western countries, because people start to retire in Western countries during that age period. Yeah, Singapore, no. Singapore, you work until you die, right? No retirement age. Yeah. So because of that, the retirement is closing, so people tend to get less depressed. Yeah, or they kind of underreport. That is the reason, right? And why are there more females than males in all age cohorts? It's not because males do not suffer from depressions. Males do, but males tend to underreport. Yeah. Males definitely tend to underreport, right? If males more come up to report, I'm sure the ratio will be 1-to-1. Yeah. So genetic contributions to MDD, all right, doesn't really matter what the genes are. It's just so many genes, but what they do target, right, is this neurochemical serotonin. Yeah. Specifically, it really affects, all these genes affect the uptake, right, of serotonin, right? And then, so there's this influence of short version of serotonin transporter gene. If you spoil that gene, okay, your serotonin does not really get reuptaken. So ultimately you don't really have enough serotonin, so that's not a good thing. Now we look at this brain structure, right, and function again in MDD. So this time is not so much about maturation, okay? We're not dealing with children, right? This thing is just about what it is, right? So it's just smaller, okay? Smaller subcortical regions, right? Our hippocampus, amygdala, even like the caudate, the striatum, I would say, can be smaller, right? And there's larger lateral ventricles. I mean, of course, yeah. So damage to the left frontal lobe, right? Frontal lobe is just such a big area. I mean, I'm not too sure. Usually the lateral regions, so it can produce depression, right? So because our left frontal lobe is kind of tied with processing of positive emotions, right? So there's lateralization, right? In this case of emotion processing. Right is more with not so good emotions, negative, but not always, right? But the conventional wisdom is that reduced left frontal activity and there's some reduced right parietal activity. Okay, that one's not so legit, but I would say the left frontal lobe activity is pretty much replicated. Yeah. So increased right frontal lobe activity, that's for people who are depressed. So that when they're processing emotional stimuli, I would say, that kind of doesn't really have to be totally positive, but it's just kind of emotional stimuli. They tend to kind of engage the left frontal lobe a bit less, right? So this diagram will look at the correlation between depression and patterns of sleep. So very, very interesting, very colorful diagram, and I think it's also very meaningful as well. So basically you see that there's almost no NREM stages 3 and 4, okay, for all these MDDs, yeah, almost no. I mean, if I'm not mistaken, there's no, right, yeah. So they have longer stretches of REM, yeah. So they fall asleep much faster in that case, yeah. Right, and treatment of MDD, this one, a lot of people know this, okay, vast majority of you know this already, so we use SSRIs. So we want to keep as many serotonin in the synapses as possible, as much as possible. Get them flowing, yeah, because it's the serotonin hypothesis. You need serotonin to make yourself feel happy. Right, then we have this Prozac, right, the most famous SSRI, yeah, most widely used as well. Yeah. And then we have CBT. Okay, what CBT is like, I have no idea. Or you guys have to practice this to get a sense of it. More of an art than a science, CBT, right? CBT is just like playing chess, right? Yeah. More of an art than a science. Increase aerobic exercise, yeah. So all the rest are basically non-medical interventions, right? ECT, ECT is a bit invasive, not very good. RTM as well, right? Deep brain stimulation. Probably the last one is the best. I just don't really know how you want to classify DBS, right? Yeah, it's still an ethical question. Is it invasive or is it not invasive? Yeah, so it's something to be solved, something to be resolved. Now we look at bipolar disorder, right? It's a bridge between psychotic disorder, depressive disorders. So there's this thing we call mania, right? Elevated mood, like usually high levels of energy, and then it can be preceded or followed by depression. Yeah. So bipolar 1 and 2 are different in the way that only bipolar 1 involves mania, right? There's no mania in bipolar 2, right? And bipolar is kind of linked to enhanced creativity. And women are slightly more likely to get bipolar than men. I have no idea why that is the case. Okay. In Western countries, okay, always remember in Western countries, does not apply to Singapore. Right? So similar brain structure as in schizophrenia. Later we get to that. Yeah. So basically your subcortical areas are affected, your frontal cortex affected, right? But do know there's this sticker TPJ, yeah. temporal parietal junction. Yeah, there is thicker area in that. Yeah, it's very, very bizarre. Yeah. And then unlike schizophrenia, larger than normal intracranial volume. Wow. Okay. Yeah. This is wow. I have no idea. Smaller brain but larger space to hold your brain. Yeah. Wow. Okay. So biochemistry treatment of bipolar disorder, right? So linked to oxidative stress. Okay. Oxidative stress, it actually requires one entire lecture to really explain what it is. But in a nutshell, okay, it just refers to the damage of our our neuronal proteins, right, our membranes, by all those reactive oxygen particles, right? We call them reactive oxygen species. It can be peroxide, can be hydroxy group, right? You guys can look it up, right? Yeah. So high amounts of DNA damage, yeah, all these things can lead to accelerated aging, right? Can lead to more unwanted apoptosis, right? More unwanted cell death, no good. So there's lithium salts, there's SSRIs, and there's benzodiazepines. They're all not very good. They produce a lot of side effects. Similar to as what we covered for ASD, ADHD, yeah, not very good, yeah. So diet, however, can improve, right, the conditions for bipolar disorder sufferers. So this one we covered, right. So there's these omega-3 fatty acids may offer good protection against bipolar disorder, right. So when you look at a place like Iceland, where is Iceland, right? Go and look it up the map, yeah. It's so hard to find, right? Compared to Germany, right? Because Germans like to eat a lot of pork, right? I think in Europe they are possibly the highest consumer of pork. Yeah, so well, I mean, according to this graph, according to statistics, they are the people in the nation with the highest bipolar disorders. All right, so schizophrenia. Okay, now this is the last one and possibly the most interesting. Right? Out of all the psychological disorders, this is definitely number one on my list. Right? I mean, along with MDD, right? The equal first. Right? So we look at positive symptoms, right? And then everything has to happen in a 1 month period, okay? Negative symptoms, why is it called negative symptoms? Well, these are the symptoms that, the kind of emotions, the kind of cognition, I would say, the kind of cognition, the kind of behavior that's just absent in schizophrenics, right, compared to healthy individuals. Yeah, healthy individuals, they have normal emotion expression, we have volition, yeah? But for schizophrenics, they don't have it, right? Diminished emotion expression, avolition, yeah? No motivation, yeah? It's that if you don't want to take quiz 2, we can say, I'm suffering from negative symptoms. I have avolition. Right, very, very good excuse. Okay, sending a special request for that. Yeah. Okay, 7 to 10 cases per 1,000. I think the 10 is right now, right? That'll be like 1 out of 100. Yeah. At least for my time, it's about that. 60% are males. Okay. So this is a male-centric kind of mental disorder. So it applies to people in college. Yeah, 18 to 25. Okay, remember the last bullet point. So yeah. So many of you here are actually at risk for getting schizophrenia. So concordance rates, so 50%, not super high, but still it is quite a number, yeah. So if you have a twin getting it, you have 50% chance of getting it, yeah. And then I just talked about abnormal saccades, yeah. Running a bit short of time, yeah. So this diagram, I took a long time to understand what on earth is happening, right? I thought when the arrow appears, you're supposed to ignore the arrow. Yeah. But no, right? So you're supposed to just go along with the flow, right? Go along with the direction of the arrow and avoid fixing on the dot. So for non-schizophrenics like us, we will just, I will just gaze. We just move our eyeballs to focus on the arrow, right? We're not fixate on the dot. Schizophrenics do the reverse. They fixate on the dot. They don't care about what is happening around them. They don't care about, the periphery. So this is something that deals with peripheral attention, I would say. So because they have deficits in divided attention, I would say that, they will tend to commit more of such abnormal eye saccades. Right? So this is a very important behavioral marker. Remember this. Now we look at this environmental influences. Okay, all these things are very commonsensical. I don't really want to elaborate too more, right? So social economic status, okay, that maybe is a bit surprising. It's higher in lower than in higher SES groups. I thought it's the other way, right? I really thought that it's the other way. But at least for America, it's lower than in higher SES groups. The first part, that one only applies to the USA, right? The first one only applies to the USA. Prenatal environmental factors, yeah, applies to all the temperate countries, right? When there's winter, it could be a case, right? But this is not a huge causal factor. So now we look at all this brain structure function in schizophrenia, which also applies to bipolar disorder, right? So smaller subcortical regions like the hippocampus, there's not so much activation in the frontal lobe, especially the orbitofrontal cortex, hypofrontality, yeah.
So there's less lateralization, not good. All right, lateralization is a good thing. All right, so because of this greater brain symmetry, you have more left-handed individuals, amongst schizophrenics. And there's also greater loss of gray matter, like a forest fire. Wow, okay. That means lower density of synapses, dendrites, yeah. So failure to produce sufficient synapses, yeah. So, for the last few slides, we'll look at a few images, right? So these are larger lateral ventricles, schizophrenics on the right. And then hypofrontality, right? This is, less, I think should be PET, yeah, should be PET. Lower degrees of metabolism, right? In the lateral, that should be the lateral prefrontal cortex, yeah, right? For the twin with schizophrenia, you guys can see this, right? Yeah, I mean the red spots disappear, and this is extremely interesting. So, so schizophrenia seems to be associated with larger losses of gray matter, and this loss appears to be larger in girls compared to boys. Yeah, okay. So more reddish colors in girls, especially the temporal region, right? If you look at it, the temporal region, lateral temporal gyrus. Maybe that will affect language processing or hearing in girls more than boys. I think that's definitely a possibility. All right, so the last few slides are a bit important because we're talking a little bit about all these chemicals involved, right? So there's this dopamine hypothesis, and there's also this serotonin hypothesis, all right, which is less strong, okay? So the dopamine hypothesis, as this graph shows, right, is just emphasizing that psychosis, may result from high levels of dopamine activity. Right, so the positive symptoms. So when you use drugs like L-Dopa, like meth, like coke, right, you're going to get all these hallucinations. So in order to control for it, you need to get dopamine antagonists, right? So dopamine antagonists form the typical antipsychotic drugs. And then the newer forms of drugs are what we call atypical antipsychotic drugs, medications. Clozapine is a very, very famous one, possibly the most famous right now. So they also function as dopamine antagonists, okay? But importantly, they function as serotonin antagonists, yeah. So they block actually more serotonin receptors than dopamine receptors. So clozapine is actually the most powerful, so-called powerful, right, anti-schizophrenia drug. And there's also glutamate, right, the other neurochemical, the third one, okay? But this one we have no idea, right? Sometimes it can be reduced, sometimes it can be increased, right? As some of you highlighted in your paper and presentation. So, but in this case, as long as the paper is concerned, like the paper shown by our author, it shows that reduced glutamate activity may be tied with negative symptoms. And then higher dopamine activity may be tied with positive symptoms, right? Hallucinations, delusions, right? I think the dopamine one is more legit. The reduced glutamate activity, that one is a bit, susceptible to future research. Okay, that one I have no idea. So so this one we talk about it. We talk about dopamine antagonists, right? Thorazine is the traditional one, and then clozapine is what is the most popular drug right now, serotonin antagonist. So the non-drug-based treatment, we talk about the psychosocial rehabilitation, work and social skills training. It's not just CBT, okay? This is not CBT. This is really just having a plan, social welfare for everybody to, get them back into life, like get them back, into work. Yeah. Better education, housing, etc. Not available in Singapore, okay? Only done in the USA, right? Okay, so this will be the end, right? Just a reminder for everybody, right? So this is our final week, okay?